I think the idea of inequity is one that is well recognized in India, and that is inequity across states and within states as well. So if we look at models around the world, there are very few places that deal with the kind of healthcare challenges that we have. The level of non-communicable diseases, the level of communicable diseases that we have. So I don't think that we can take something that is on a shelf somewhere and apply that to India. And that's the reason. Now, if we look at model systems within the country that have tried to integrate provision of care across scales, there are examples, but those examples have not necessarily scaled. So understanding the challenges in scaling what is already existing good practice in the country will help us identify which components of the roadmap need to be developed greatly or lesser in different locations. So the center-state relationship is one that requires us to think about what needs to be done at which level, both in terms of policy, in terms of regulation, and in terms of execution.
Because another challenge, Dr. Patel, is in a country like India, ensuring a public-private partnership. In your stakeholders, in the commission, you have representatives who've served in government, you have others who distinguish themselves in the private sector. Now, that may work in the commission, but in the wider world out there, how do you achieve an element of trust and partnership between public health services and private health services, given that their goals are very different?
Yeah, I think, Rajdeep, this is a challenge that is also not unique to India. I mean, let us not forget that in 1945, when the UK's National Health Service was created, the entire system of healthcare looked exactly like the one in India today. That there was essentially a private healthcare system that catered to the rich from Harley Street, etc. And then you had the kind of very low-funded, poor-quality public hospitals for the poor. Even today, it might surprise many people to know that in many parts of the world that have universal health coverage, in which the citizen pays nothing for healthcare except through their taxes or other kinds of prepayment methods, the providers are often private operators. For example, every general practitioner in the UK is really, actually, practically speaking, a private provider. So I think, we can learn from other places. I agree with Gagandeep that we do have to develop a homegrown system. We also have to recognize that every state will have potentially a different kind of model because, of course, most spending on healthcare is actually at the state level. It's not a central expenditure, it's a state level. I think it's about 80% is actually spent at the state level. But